Hi, my name's Jackie Hislop-Jambrick. I'm a global scientist with Canon Medical based here in Australia, and I'm in charge globally of the musculoskeletal research endeavour that we have going. What I'd like to do today is discuss radiology, and what do I mean by that? I'm going to talk a little bit about imaging anatomy, a little bit of physiology as well, and a bit of radiobiology. Why is all of that important? Well, what I want you to have at the end of this lecture is an understanding of why it is that we perform radiological procedures, what's important about those procedures, and why it is that any radiological procedure is a balance between what we want to get out of actually doing the imaging and the risks associated with performing those imaging procedures. And that's important, especially when we're considering things like ionising radiation that we use in X-rays and in CT, and I'll talk more about that as we progress on. Why is it important? Why is radiology important? I guess from the perspective of the older X-ray technology, or I call it old, but we're still doing lots and lots of these procedures every single day. The normal, or what we call the traditional X-ray or 2D procedures. If I show you on the slide here, this 2D representation, you have a look at it and you can think, well, it's a bit abstract, but as soon as I start to add the 3D component into the structures that we're imaging there, you start to get a better appreciation of what it actually is. And that's what we're moving to more as we advance the field of medical imaging, is we're looking more and more at the 3D structures, more and more about the size and scope of disease and pathological processes. And we're delving more and more into what's called quantitative imaging too. So not only are we looking at what something looks like, its physical presentation on the screen, the qualitative aspects of it all, is it fractured, is it not fractured, but also in the quantitative aspects of it all, and we call that bioimaging markers or biological markers, X-ray markers. We'll talk a little bit about that as we go on as well. Now, when we think about plain X-rays, we're reminded of the fact that one image or one 2D image is not quite enough to give the complete story, and there's an image on the screen there of a mallet fracture of the distal phalanges, the distal phalangeal tuft that's fractured. If you look at it in the PA orientation on the left-hand side of the screen, and then look at it at the lateral orientation on the right-hand side of the screen, you can see the differences that those two dimensions give you in terms of demonstrating the significance of that fracture. And that's really important in medical imaging in terms of how you treat it. Another example I've got on the screen here is a tibial plateau fracture. In the middle you can see a volume rendered CT scan, and on the left-hand side an axial CT scan, and underneath that a coronal T2 weighted MRI scan. On the right-hand side you see the 2D image, which really doesn't give us especially much information. You can see the fracture line. You can see the fracture line throughout, but it's not particularly easily shown, whereas the other imaging modalities, the 2CT and the MR images, show that quite nicely. So often it's not just about looking at the 2D methods and combining those, but it's about combining other imaging methods and getting the answers that you're after. When we talk about X-ray parameters, obviously, if we're doing a PA or a lateral chest X-ray, we've only got 2D, so we've got an X and Y component to our picture elements, our pixels. Once we add the third dimension, they're called voxels, and we add onto that a Z-axis rotation, or a Z-axis to that. And when we talk about X-ray parameters, we also talk about resolution, the noise, same as what we do when we take out our camera, whether that's our iPhone or a proper, as I say proper, as you can tell I work for Canon, a proper Canon camera where you're taking a picture. Your resolution and your noise are very much affected by how much light's hitting the detector. In X-rays, or when we're using X-rays, we talk about not so much light but photons that hit the detector banks. and they're controlled in their contrast and brightness through the power that we deliver into that X-ray tube, milliamps and kilovolts. Milliamperage, or the amount of amperage through the X-ray tube, is how many photons are produced, and the kilovolts, or the kVp that we set up, sets the penetrating force of those photons that we use in X-ray. Generally in traditional X-ray systems, certainly in modern day systems, we have automatic exposure control. So once the detector on the other side of the patient detects that enough radiation or enough photons have actually hit that detector to create an image, they'll stop and turn it off. It's a safety control mechanism, and it's also a mechanism that maximises the image quality characteristics. When I talk about spatial resolution, it really is a balancing act. I can deliver a fantastically clear, pristine image every single time if I'm given as much or as many photons as I possibly want to use in any one particular image. If you have a look here at this is a 3D render of a CT scan of the inside of a person's bowel. It's a procedure that's done in place of a endoscopy. And you can see at 5 millimeters resolution, you can see the convolutions of the large bowel quite nicely. At 3 millimeters resolution, they're even nicer in terms of their resolution. And at 2 millimeters resolution, you start to see little convolutions that kind of don't match the rest of the surround. You can see that in the centre of the image. And at 1 millimeter resolution, you can quite clearly see a polyp that resides inside the bowel of this particular person. As I said to you before, we can produce these particular resolutions at any time we like with modern X-ray procedures. The biggest issue with delivering these sorts of image quality parameters is the fact that we use more and more radiation dose, and I'll talk a bit more about that in a moment. What we also talk about with resolution is image noise, and you can see quite clearly here with this phantom up on the screen at the moment. Now you can see the various sizes of the discs that are placed inside. These discs are in the phantom various attenuation characteristics, so the photons will actually bounce on or bounce off them or run through them, depending on, as I said to you before, the milliamperage or the kilovolts used. And you can see this one here generated, there's absolutely no noise. Once we start to add noise, you can see that the definition of those bits within the internal structure of the phantom become less and less visible, and certainly the smaller beads at the bottom of the scan, the smaller and the less dense beads are increasingly difficult to see once we add more and more noise. So this adding of noise is less photons actually being delivered into the system and hitting the detector on the other side. It's kind of like when you go in taking your camera into a darkened room and you don't have the use of the flash. You can see the pixelations, the noisy characteristics on your film, and this is exactly the same thing that happens when we're using X-rays to produce an image. And as I said to you before, it's a balancing act between trying to produce a diagnostic series, because obviously on the image as it exists on the screen now, we can see very roughly, but we can see very dense and large structures even with 90% noise. So obviously if we're looking for larger, very conspicuous lesions, it is possible for us to use very, very low dose techniques and get a good quality or a quality examination just with those low doses. But obviously if we're looking for very, very small, subtle lesions that aren't attenuating or bouncing the X-ray beam particularly much, then we do need to deliver a lot more radiation. So everything that we do when we're using these sorts of techniques is balancing between the image quality characteristics that we're requiring and the radiation burden for the patient. We can also adjust the image quality characteristics through the use of windowing, and that's a bit like adjusting your contrast and your brightness on your images from your camera as well. You can see on the upper left-hand side of the image, this is a window width of 1500 and window level of 300, and that's looking at the soft tissues. These are all the top two are axial scans through the pelvis, and the bottom are axial scans through the liver. Now, what window width means is that we only can see between about 10 and 14 shades of grey. As radiologists get more and more used to looking at images, that can go up to about 16 or so, but the human eye can't really see differentiations between different shades of grey particularly well, even when trained like a radiologist. That's why artificial intelligence is being quite excitedly talked about. But I digress. When I talk about window width and window level, what we're saying is, if I talk about 0 being the window width for water, negative 1,000 being negative 2,000 being the window width for air, and positive 2,000 being the window width for bone, then you look at that image there. The window width is well and truly over towards my bone setting, and the window level is how many of those grayscales that you can see. So it's a very wide range of values. If you look at the right-hand side, my window width is down a lot closer towards the water. Remember, water was at 0, so I can see the bladder in the upper part of the image, and I can start to see the differentiation of the soft tissues. And my window level, the number of windows, or the number of grayscales that I can see, is a lot more reduced. And so you start to get the soft tissue characteristics. And down the bottom in the image there, I've shown you the difference, as I said before, talking about the amount of radiation, the amount of photons that are hitting the image detector. I've used 25 milliamps per second on that lower right-hand image, and you can see quite clearly that liver lesion. And you see that black spot, and on the right-hand side I've delivered 200 milliamps per second, a lot more radiation dose, and you can see that a lot clearer. The question that you need to ask yourself is how do we balance out between the amount of radiation we use and the ability to control the window width and the window level to actually extract from that image the characteristics that allow a diagnosis. In order to do that, we can add things like contrast media that change the attenuation characteristics of the beam. On the upper left-hand side, you can see the contrast media. You can see this is an abdominal scan. You can see the black within there, that's gas within the bowel itself, and the white is, of course, the bone. The white on the right-hand side of the patient, left-hand side of the image, is actually the right kidney. Contrast media is injected into the patient and preferentially excreted through the kidneys, and we use that method of excretion to show up on the X-ray images themselves, this radiodense iodine, which is extracted through the kidneys and flushed out into the bladder. The middle image is an axial scan, CT axial scan. You can see once again on the right-hand side of the image, the left-hand side of the patient, the kidney, the round shapes that look, I suppose, that are the kidneys. You can see a renal cyst. The top right-hand image, you can see on the patient it's an T1 weighted MRI scan. You can see contrast media that's been absorbed within the brain lesion. It's crossed the blood-brain barrier and exists within that patient. It's a glioma, a significant glioma in that patient. Bottom end, we've used contrast media in the liver, and you can see those white dots throughout the liver. In the centre is another axial CT scan, and this one I include because I wanted to demonstrate to you on the upper right hand side, even though it's a different imaging modality, you can see that glioma is fully encased in contrast media. The contrast media encompasses the entire lesion. It's a very vascular lesion. If you look down at that middle image with the CT scan, you can see that there's this dark spot, so it's much more towards fluid than it is air or bone. And you can see that the contrast media has got this ring of enhancement around the outside. So the outside's the vascular part of that tumour, and that's actually a cyst. So giving contrast media not only delineates these structures, but gives a better idea about the pathophysiology. It gives a bit about the physiology of actually what's happening within those lesions themselves. And on the right-hand side, that's an injection of contrast media into the uterus and flowing out into the peritoneum. As I said to you before, I really do want to concentrate a little bit on the biological effects, because it is one of the questions that we ask is when we say, okay, what's the best procedure to show what it is that we want to see in these examinations? When we talk about radiation, there are two different effects, the stochastic and the deterministic effects that we talk about. Now, they're risks that delivering this degree of delivering this degree of radiation is going to produce a cancer or a deleterious cancerous effect. Stochastic, that's a probabilistic effect, and it's something that we talk about in terms of taking 10 to 30 years to express as pathologies and genetic mutations. They're normally quite high in radiation doses, but they certainly are in the realm of the doses that we use in diagnostic X-rays, and that's why we try to keep images or keep imaging procedures that use ionising radiation down to as low as possible. Deterministic effects are not particularly often seen with imaging, medical imaging. There are some articles, if you'd want to go onto the internet and type in something like CT burns, you can see deterministic effects. So a CT scan that's done on a patient's head where their radiation safety mechanisms have not been adhered to, and you can see burn marks where the radiation has actually created burns, and they're the effects. These deterministic effects are seen within days, and in some instances in hours after a procedure. They're not they're not at all common with X-ray procedures themselves, and shouldn't really be seen. They can be seen in radiation therapy, but certainly not in the diagnostic sphere that we're talking about. So what do I mean by doses? The Australian and all the governments have a background radiation dose that's expected. The Earth is created in quite a hot environment, hot radiologically speaking. So we all receive around about here in Australia, it varies from region to region, about 3 millisieverts per year. That's the ARPANSA dose rates. And so what we normally do with radiological procedures is we look at the doses, the effective doses that are delivered in a particular procedure, and then we compare that back to the radiation, the Australian background radiation dose. So you can see on the top there, a CT head delivers about 1.5 microsieverts, an effective dose. So it's about 150 days worth, all the way down to looking at another CT head scan at 2 millisieverts. If you think about it like that, it's 9 months. A chest X-ray is tiny in terms of just 2 days. And a CT abdomen, and this varies, of course, from practice to practice, 10 millisieverts will deliver around about 3 years' worth of background radiation dose. So that's these are the mechanisms that we use to try and monitor and keep radiation doses as low as possible. Why do we do that? If you look here at the cancer risk table up on the screen now, you can see that the younger the patient is when they're exposed to radiation, the more chance they have to developing up cancers and that reflects back on that stochastic discussion that I had previously, stochastic risk. So then they have lots of these procedures, and when they're very, very young, they're very, very well for 10 years, 20 years, and then all of a sudden develop cancers. The link between those two, there's a lot of debate about how much the doses are and how strong the links are. But it's a known fact through our examination of things like the Fukushima and like a lot of the Hiroshima bombs, all of those sorts of things. We have a lot of data now that show links between exposures at different rates and at different times of a person's life. Now, once we balance out all of these discussions about what radiological procedure to use, I just want to finish off part one by talking about X-rays, the normal traditional 2D stuff, the stuff that's used every day. When you're looking at these films, a few tips that I give to students and to people that I deliver talks to is look for symmetry. The beauty of the human body is that usually if we're looking at the left wrist, we've got the right wrist to compare it to. Not that we're going to actually X-ray both wrists all the time, but what I'm saying is that if you have symmetry, if you've got one side to compare to the other side, then do that. What you're looking for is a consistent contour. So if you are looking at the right wrist and you see a break or a break in the continuity, then that's more than likely a fracture. You want the human body relies on, or when you're looking at images of the human body, you need smooth changes in contrast, density, and detail. Once you do see pathology, it's a good idea, especially with some of the 3D imaging techniques, and especially with some of the newer technologies, to run through and just make sure that that's not an artefact. Artefact is quite common in this balance between trying to keep the dose as low as possible, but to produce really good imaging characteristics. Often algorithms are not particularly perfect, so you do need to make sure that an aspect of an image that you think is pathology is actually pathology. And you need to look at the fact, as I said before, that it's much better to look at something in 3D than in 2D. And so once you that image with the finger, if we go back to that image with the finger, the distal tuft, you could see very different details in the anatomy of that fracture, the pathological presentation of that fracture from PA to lateral. And just try and whenever you're looking at your patient's images, and I do encourage you to do that, have a look at the images and think about it. Try and close your eyes and think about them in 3D. If you're looking at an image in 2D, especially if you've got a 2D image, like an X-ray image, and you've got the CT scans or the MRs or the ultrasounds, have a look at it and try to picture that person or that particular pathological presentation or that particular imaging anatomy area, the anatomical area in 3D. And lastly, I put down on the list things that seem not quite right. There's a learning curve. I'm going to show you some images, but you're not going to be an expert at the end of this presentation. You need that thing by Malcolm Gladwell that you need 10,000 hours is probably fairly close to the truth when it comes to imaging anatomy here. You do need to sit down, have a look at images, read through the reports from the radiologists and get used to looking at images and looking for disease and looking for pathology, and I encourage you to do that. So when we talk about wrist and elbow fractures, I'm just going to whip through a few here just to show you what I'm talking about. You see on the upper image, I'm sorry, I haven't got a mouse to put up on the screen. I'm sorry. Upper image, the Colles fracture. You can see on the radius quite a clear break. You can see on the lateral image the fact that it looks like there's what's called a dinner fork deformity, so it kind of goes up, hooks back and front on itself. A green stick fracture, you can see what I was talking about before. You see a discontinuity of that margin, and number 2 is pointing to that. Number 1 is pointing to the epiphyseal plate, because obviously green stick fractures occur in those there where the bones aren't fully formed. got a scaphoid fracture, and that occurs. You can normally tell those if you put your hand, if in front of you, put your hand on the desk in front of you, or in the desk in front of you, and tilt it out towards the outside of your body, so the tilted out laterally, and you can see what's called the anatomical snuff box. At the base of your thumb there'll be this little divot, and your scaphoid lives in there. Most times with a scaphoid fracture, all the time really, with a scaphoid fracture, if you push a patient somewhere around with a fracture, they won't be particularly happy about that. But it is quite a common fracture. Sometimes it occurs and it's really, really difficult to see on plain film. Patient comes back 10 days later, still painful, comes back 2 weeks later, still painful, and the x-rays show established non-union because of the blood supply. The actual blood supply goes through the waist of it, and in fracturing it, they snap off the blood supply and create a situation where established non-union exists. So that one's quite a fracture to look out for. If you follow that down, you've got an olecranon fracture, normally young kids falling off monkey bars. Same with the humeral fracture that you see in the centre there. Those ones are quite important to notice. If you just have a look at that, focus on the soft tissues behind the elbow itself, and you can see that change in, you've got a nice smooth skin, and you go in, you see this dark area. That change in attenuation is quite indicative of the underlying blood that's pooling within the soft tissues itself. Those particular humeral fractures, again, monkey bar type things, kids falling off monkey bars, are quite important. It's important to make sure that they have a pulse distal to that fracture. Often those fractures are quite significant in that they cut off the circulation to the distal end of the arm and need to be reduced quite quickly. You can see a Smith fracture down the last image on the left-hand side, and that's the opposite of a Colles fracture. Colles is fall on outstretched hand or fush, and a Smith is fall on instretched hand. Got ankle fractures. They're traditionally called the Potts fracture. So you fracture either one of the 3 malleoli, medial, lateral and posterior malleoli, and you can see those fracture elements there. And then the yellow arrow is pointing at a tuberosity on the calcaneum, which is called a calcaneal spur. You can see actually quite clearly, if you have a look, if you've got a good image quality in front of you, you can see the changes in the soft tissue too. You can see a bit of pooling there. And a calcaneal fracture on the right hand side. You can see the calcaneus, see the break posteriorly. If you follow the lines, you can see quite clearly where that's fractured, both at the proximal and the distal ends of that particular bone. It's very clear, just following the borders. And then lastly, for the ankle, this is a patient who had previously fractured their ankle skiing. So you can see it's at the top of the boot. I think it was snowboarding. And they were subsequently involved in a car accident where the airbag, they must have had their leg up on the dashboard. Anyway, the airbag went off and blew into their ankle and refractured the bone, but also bent the plate that was keeping those two ends together. Quite a nasty fracture. Clavicular fractures, very, very common. I think that something I read was about 5% of fractures that occur are clavicular fractures, very common, falling onto the point of your shoulder. Most common fracture is the Colles fracture that I talked about before, the one in the wrist. But this actually, I tell a lie, I believe that the clavicular fracture is the most common fracture, but what I've seen in medical imaging is probably more of the wrist fractures. So clavicle fracture, and back to the side, clavicle fracture is one of the most common, or the most common fracture seen in our radiology departments. Can fracture anywhere along the line of the clavicle itself, and you can see those quite clearly defined in those images that are up on the screen now. Got digit fractures, or fractures of both the hands and the feet, normally occurring in metatarsal or the carpal bone or the metacarpals. As I said before, the carpal bones also get involved, and so do the tarsal bones get involved, but more often than not you can fracture within the metatarsals and the metacarpals themselves. Boxer fracture on the right hand side, usually people punching walls. Bennett's fracture is people that clenched fist into a wall with their thumb inside the fist. Commonly end up with that. The multiple metatarsal fracture, people normally kick things, and often I've seen significant injuries involving lawnmowers as well, significant fractures involving lawnmowers and those sorts of things that are close to the ground. And down on the right hand side you've got rheumatoid arthritis. Dislocations are also one of those images that you'll see quite a lot of, posterior and anterior dislocations. In the middle you'll see a shoulder. Shoulders normally dislocate anteriorly, as do elbows. Elbows usually anterior dislocation. Fingers, well, it just depends. There's an example of posterior on the left hand side, and as you move more medial to that, other fractures and that they can, other dislocations, and they can occur at any of the carpo-metacarpal joints or metacarpophalangeal joints. Dislocations in the lower limb, knees, ankles, hips. Hips usually dislocate posteriorly. I said before, shoulders anteriorly, hips normally dislocate posteriorly. And one of the things that they show on TV about getting these shoulders and hips back into place is actually true. That's what they do. They lay them on the ground or sit them in a chair and try and pop them into place. Usually they do an x-ray beforehand just to make sure that they are true dislocations and not fracture dislocations. The image on the upper right hand side is a patella that's dislocated, and the bottom ones are toes. And just to kind of finish off, when we talk about balancing between an x-ray procedure, the x-ray, what it is that we're getting out of the procedure and the radiation dose and the risks to the patient, chest x-rays are done all the time. They're a very, very useful exam, and they're fantastic for you to have a look at. If your patients have got chest x-rays and you get the report, it's a really great way of learning and having a look, training yourself to look at the soft tissue changes. So you've got the lungs that don't attenuate the x-ray beam or the photons particularly much, and you've got the bones that attenuate a lot, and then you've got the cardiac structures in the middle that attenuate kind of midway between. It's a great way of training your eyes into getting to know the differences between these attenuation profiles, and it's a good way to train yourself. And as I said before, they're especially well used in radiology. If you look at the image on the right hand side, the lateral of that patient, you can see the costophrenic angles right in the bottom of the screen there. Those costophrenic angles can hide up to 500 mils of inflammatory exudate from things like infection and those sorts of things. So that's why we do a PA. So you can see on the PA the diaphragm itself and those costophrenic angles there. You can, between that film and the lateral film, can hide 500 mils of fluid, free fluid within the lungs themselves. So that's why we do two views at right angles to each other, because you might be looking at the lateral thinking, oh, it's a bit hard to see anything there. But that's what the lateral is used for mainly, is to look at those costophrenic angles and look at the alignment and look at the mediastinal components of the lungs itself. It's quite an important exam. So that finishes